Imagine walking into like a super high-tech modern clinic for a prenatal checkup. You're looking at a 3D ultrasound, you're surrounded by all this cutting-edge technology, and then your doctor counsels you on the risks of an upcoming procedure using a statistic from 1986.
Yeah, which is wildly outdated.
Right. It's the era of blindfolded crop dusters,
Yep.
basically, and it is happening in consultation rooms today. So welcome to today's deep dive. We're unpacking a genuinely fascinating, highly technical presentation on invasive prenatal diagnostic testing, or, IPDT. And our mission today is to decode this specialized clinical data because it reveals this massive system-wide paradox in modern medicine.
It really does. It's the ultimate unintended consequence of medical innovation. What we're exploring today is this really fraught transition from what we might call the blind medical era into the precision era. And understanding this data, I mean, it goes far beyond just medical trivia. Knowing how these systems are failing to update is, well, it's the ultimate tool for patient advocacy.
Exactly. And I want to jump straight into, I think, the most baffling takeaway from this entire presentation. Because here's where it gets really interesting. It wasn't some futuristic laser surgery thing. It was the fact that medical professionals are actively terrifying pregnant patients using a risk statistic from 40 years ago, from 1986. That math is entirely obsolete.
Completely obsolete. Yeah.
So wait, I have to stop and ask. If the actual present-day risk is so much lower, why on earth is a 1986 statistic still alive in patient counseling? I mean, are clinics just being lazy?
It's really easy to assume it's laziness, but it actually stems from institutional inertia and, a really deep-seated fear of liability. To understand why we're stuck, we kind of have to look at the baseline. So back in 1986, there was this landmark randomized trial that established what became known as the 1 in 200 rule.
Okay, 1 in 200.
Right. They determined there was a 0.5% loss rate, meaning a risk of miscarriage associated with invasive testing like amniocentesis. And for decades, I mean, that was the gold standard number. It was written into every textbook, every single liability waiver.
1 in 200. Which, I mean, that sounds incredibly daunting if you're a prospective parent sitting in the clinic weighing your options, right? But let's look at the present data. From the precision era, so covering roughly the year 2000 to the present, contemporary expert centers are operating at a staggering 0.06 to 0.22% risk rate.
It's a massive drop.
The presentation cites multiple contemporary experts proving this, so the procedure is exponentially safer now. I mean, judging modern medicine by that 1986 statistic is literally like judging the safety of flying on a modern commercial jet based on the crash statistics of like a 1980s crop duster.
Your crop duster analogy is actually perfect because, well, flying blind is precisely what doctors were doing in the past. It's not just that doctors, slowly got better at wielding a needle over 40 years. The entire medical field shifted to a fundamentally new technological paradigm.
Right, they aren't just practicing more. The tools completely changed.
Exactly. Before the 1980s, these procedures were performed via blind or statically guided punctures. So doctors were essentially feeling for physical landmarks on the patient's abdomen and just hoping for the best, which, as you can imagine, carried a terrifying 5 to 10% complication rate.
Wow. A 10% risk of losing a pregnancy just to run a diagnostic test is staggering. I can entirely see why that 1 in 200 stat felt like a massive victory in 1986. But how exactly are they doing it today that drops the risk all the way down to 0.06%?
Today relies on continuous, real-time, high-definition ultrasound guidance. So instead of taking a static picture and then inserting a needle blindly, the physician is literally watching the needle trace its path on a high-definition monitor. They're adjusting millimeter by millimeter in real time, completely avoiding the fetus.
So it's basically like a live GPS.
Yes, exactly like an HD GPS. And that 1 in 200 figure ignores this mechanical revolution completely. It is mathematically obsolete, and frankly, the data says it must be definitively retired from patient counseling. You have to give people an accurate picture of their options.
Okay, so we have this HD GPS for the womb now. The logical conclusion would be that doctors can safely perform these tests whenever they want, right? Just boot up the HD ultrasound and go.
Yeah.
But looking at the diagnostic matrix and the data here, that is absolutely not the case.
Not at all. Having better vision actually created way more rules.
Yeah.
Because we can see the biological environment in such incredible detail now, the precision era demands absolute rigid biological boundaries. We now know exactly when we should not intervene.
Right, because we understand the mechanical development of the fetus so much better. Let's walk through these timelines, what the presentation calls the absolute do-nots, because they're incredibly strict. Chorionic Villus Sampling, or CVS, which is where they test a small sample of the placenta, is strictly prohibited before 10 weeks of gestation.
Highly prohibited.
The presentation mentions research linking early CVS to severe transverse limb reduction defects,
Right.
which sounds terrifying. Why would touching the placenta affect the baby's limbs?
Well, at that early stage of development, the biological environment is incredibly fragile, right? The limbs are actively forming. If a doctor disrupts the developing placental bed before 10 weeks, it can temporarily compromise the microscopic blood flow.
Oh, wow, so it just cuts off the supply.
Yeah, that brief interruption in vascular supply to the developing fetus is literally what halts the growth of the limbs.
That makes perfect sense when you explain the blood flow mechanism.
Hmm.
And then for amniocentesis, where they test the amniotic fluid, that is prohibited before 15 weeks. The data shows doing it earlier carries a 1.3% risk of causing clubfoot.
Ah.
What's the physical mechanism there?
So, amniotic fluid isn't just liquid. It acts as this crucial physical cushion and provides the necessary space for the fetus to move and develop structurally. Before 15 weeks, the overall volume of that fluid is quite low.
So if you take some out.
Exactly. If you extract even a small sample for testing, you are drastically reducing that protective space. Without enough room to move, the developing feet can become literally compressed against the uterine wall, resulting in clubfoot.
It is entirely about the physical space. That is wild. And it actually brings up another mechanical issue from the science. It's not just about when they do the procedure, it's how they physically extract the sample. The tools really matter.
The tools are critical.
Help me translate some of this specific medical jargon, because it feels like a massive hidden risk for a patient.
Right.
What is the real physical difference between a doctor using a, quote, biopsy forceps versus a malleable cannula during a CVS procedure?
Okay, so think of a malleable cannula like a dull, flexible straw. When doctors use suction to pull a sample of the placenta through that dull straw, it drags and tears the surrounding delicate placental bed.
Ugh, that sounds awful.
It is. That mechanical tearing causes unnecessary bleeding and trauma. Biopsy forceps, on the other hand, act like microscopic scissors. They cleanly snip exactly what is needed without pulling on the surrounding tissue at all.
So the cannula is literally just ripping tissue blindly. And the data reveals the consequence of that. Using the cannula is a 10x risk multiplier. It jumps the loss rate all the way up to 3.12%, whereas the forceps carry a deeply minimized excess loss of just 0.27%.
It's a huge disparity.
Yeah, the mandate here says the malleable cannula must be immediately audited or retired entirely. 10 times the risk just from a doctor picking the wrong tool off the tray is wild.
It really highlights why procedural audits are so necessary. Doctors get comfortable with the tools they trained on decades ago, even when the mechanics of those tools are proven to be dangerous.
Okay, so we've eliminated the clumsy tools that cause physical trauma. But what about the microscopic environment? Whenever you introduce a needle into the womb, the instinct is to worry about infection, right? Did these new guidelines overhaul how doctors use antibiotics?
They did, completely. For a long time, the dogma was to just pump patients full of prophylactic antibiotics to prevent infection of the fetal membranes. But the universal consensus now, which is confirmed by recent clinical trials, is that routine antibiotics have absolutely no significant protective effect in these procedures.
Right, none at all.
None. They're actually prohibited as a routine measure now. The only standard is strict asepsis, meaning a perfectly sterile procedure environment from the very start.
Okay, so no obsolete stats, no tearing tools, no early timelines, and no unnecessary antibiotics. Let's escalate this a bit. What does all this mean for the most complex, high-stakes scenarios, like twins or, taking a sample of actual fetal blood?
Well, the more complex the biological environment, the more dangerous legacy techniques become. Consider twin gestations. If a doctor needs to test both twins, there was this old method called the sliding technique.
The sliding technique sounds risky.
It was. They would use a single needle, sample the first amniotic sac, and then essentially push that same needle through the dividing membrane directly into the second sac. And the rationale was to avoid giving the mother a second skin puncture.
I'm trying to picture this sliding technique. Why is it so dangerous to just push the needle through into the second sac? Fewer pokes sounds better, right?
Imagine trying to shoot an arrow through two tents placed right next to each other. When you pierce the first tent and push directly into the second, you're going to drag the fabric and whatever biological debris is on it directly into the second tent's isolated space.
Oh, wow. So you're just dragging material from one baby to the other.
Exactly. It causes massive cross-contamination and membrane disruption. That single needle sliding technique carries an unacceptable 7.69% fetal loss rate.
That is statistically disastrous. 2 clean needles prevent that cross-contamination entirely, I assume. And the mandate requires exactly that, the sequential double needle approach. It might sound more invasive to a patient to get poked twice, but the data proves it drops the procedural loss risk all the way down to 1.53%.
Yes. For twins, the double needle is the absolute mandatory standard now.
So let's look at an even riskier scenario then. Cordocentesis, fetal blood sampling, where they take blood directly from the umbilical cord. The data says if done before 17 weeks, there is a 20% complication rate.
Yeah, it is the highest risk invasive modality we have. And that brings us to what's known as the Leiden blueprint. It's the exact protocol that finally improves survival rates for these highly complex intrauterine procedures, taking them from about 88% up to 97%.
The Leiden blueprint reads like a master pilot's emergency pre-flight checklist. It mandates targeting the umbilical vein exclusively, preferably where it is fixed solidly inside the fetal liver, and the absolute elimination of arterial punctures.
Arterial punctures are the real danger zone there.
Yeah, the slides show arterial punctures carry an odds ratio of almost 11 for severe complications. To put that in perspective for you, the listener, kidding the artery isn't just a minor mistake. It makes severe complications almost 11 times more likely. It is the difference between a routine procedure and a critical emergency.
Exactly.
But there's one step on this checklist that is incredibly jarring to read. Routine fetal paralysis. Using a drug to temporarily paralyze the fetus, I mean, that sounds incredibly counterintuitive and scary.
It definitely sounds alarming to freeze a developing fetus, absolutely. But consider the mechanics of the procedure. You're trying to insert a needle into a vein that is literally just millimeters wide, and your target is inside a moving, active fetus.
Right, babies kick.
Exactly. If the fetus kicks or shifts at the exact wrong millisecond, the needle slips from the vein and tears the artery.
We just established the artery puncture is the massive danger zone.
Keeping the target completely still is the exact biological mechanism that prevents those catastrophic arterial punctures. The paralysis drug has a massive protective effect because it guarantees precision. You are controlling the most volatile variable in a high-stakes environment.
That makes total sense when you frame it like that. Okay, so we know how to safely get the physical sample now. We have the real-time HD ultrasound, the microscissors forceps, the double needles for twins, the paralysis protocol for blood sampling. But, it begs a massive question. Why are we doing this? Why do we even need to poke around with needles in the womb if we have those fancy non-invasive blood tests now?
You're bringing up NIPT. Non-invasive prenatal testing, which is, just a simple blood draw from the mother's arm. It is revolutionary and it's incredibly popular. But it comes with a massive misunderstood caveat called the CPM trap.
Confined placental mosaicism. We really need to walk through the biology of this because this feels like the linchpin of the whole modern prenatal system. Why would a simple blood draw be a trap?
Well, when a mother gets an NIPT, the test is looking for cell-free DNA floating in her bloodstream. And people assume that DNA comes directly from the baby. It does not.
Wait, really? It's not the baby's DNA?
No, it's actually DNA shed by the placenta.
So the placenta is acting as like a genetic proxy for the fetus?
Exactly. And most of the time, that proxy is perfectly accurate. But in about 1 to 2% of cases, a biological quirk happens. When the fertilized egg first starts dividing, some cells are destined to become the fetus, and others branch off to become the placenta.
Okay, tracking so far.
Sometimes a random genetic mutation happens only in that placental branch. This is confined placental mosaicism. The cells in the placenta have a severe chromosomal issue, but the actual fetus developing inside is perfectly healthy.
Oh, wow. Let's apply this directly to you, the listener.
Yeah.
If you are sitting in the clinic and your doctor recommends NIPT, you're probably thinking, great, just a blood test, zero risk. But if you get a scary abnormal result from that simple blood draw, you're telling me you can't just trust it blindly.
Right. NIPT is a screening test, not a diagnostic test. If your NIPT comes back positive for an abnormality, but your ultrasound shows a perfectly developing fetus, you are likely caught in the CPM trap.
So what do you do?
Here is the strict clinical mandate. In that scenario, a CVS procedure, which, remember, tests the placenta, cannot confirm the result.
Because if you test the placenta again, you are literally just testing the same abnormal tissue that triggered the false alarm in the first place.
Precisely. You're just repeating the error. So an amniocentesis becomes medically mandatory. You have to wait until 15 weeks, test the amniotic fluid, which contains the actual shed fetal cells, and confirm the true chromosomal makeup of the baby itself.
That is so important.
It really is. Acting on an isolated positive NIPT without an amniocentesis could lead to terminating a perfectly healthy pregnancy.
That is a heavy realization. It really underscores why we need these invasive tests to be as safe and precise as possible, right? They're the ultimate fail-safe. And the genetics we are looking at with these tests are escalating, too. The presentation outlines what they call a genomic yield staircase.
Right. The field is moving way past the basic karyotype, which just looks at the general shape and number of chromosomes under a microscope. The new evidence-mandated first-line test for any structural anomalies seen on an ultrasound is the chromosomal microarray, or CMA.
The data shows CMA provides an additional 6% diagnostic yield. How does it find things that the karyotype misses?
CMA zooms in much closer. It acts like a high-resolution scanner that catches microdeletions and microduplications in the DNA strand. These are pieces of genetic code that are way too small to see with standard chromosomal mapping, but, they have massive developmental impacts.
And the absolute top of that staircase, the new frontier, is trio exome sequencing, testing the fetus and both parents simultaneously. It yields a massive 23 to 30% diagnostic improvement for complex cases. What exactly is an exome, and why does testing it give such a huge boost in answers?
The exome is the crucial 1 to 2% of your entire genome that actually codes for proteins. It is the active blueprint of the body. By sequencing the fetal exome and comparing it instantly to both parents, we can spot incredibly rare newly formed mutations that explain severe developmental anomalies.
That sounds incredible.
It is, however, there's a significant logistical catch. The laboratory turnaround time for trio exome sequencing is currently 3 to 8 weeks.
3 to 8 weeks, which frequently exceeds legal termination windows. So you're getting the most detailed genetic answer possible, but it literally arrives too late to make a decision about the pregnancy.
Yeah, which fundamentally reframes the exome. It's no longer just a prenatal diagnostic tool, it's a perinatal management tool. It tells the neonatal doctors exactly what complex condition to expect and how to treat the infant the very second it is born.
Okay, so we've built this incredible system. We have microarrays, exome sequencing, Leiden blueprints for complex surgeries. But because NIPT, that simple maternal blood draw, is so revolutionary and easy, it has become the primary screen for everyone.
Right, it's universally adopted.
And this massive technological success has triggered a terrifying systemic backfire. This brings us to the climax of the whole presentation, really. The NIPT volume safety paradox.
This is where public health policy just crashes headfirst into clinical reality. Because NIPT is so effective at screening out low-risk pregnancies, the population-level volume of invasive procedures has plummeted by 50 to 70% over the last decade.
Let me make sure I'm grasping the scope of this. The non-invasive test is literally making the invasive test more dangerous. That is incredibly ironic. I mean, diagnostic success is actively destroying the manual procedural volume required to keep the backup system safe.
It is a devastating paradox. Less volume means eroding operator experience. Invasive prenatal testing relies on highly refined manual proficiency. If doctors aren't performing these complex needle procedures regularly, they just lose their mechanical edge.
And the data on this is brutal.
Extremely brutal. A massive study showed that in low-volume departments, which are clinics doing fewer than 500 procedures over 10 years, the fetal loss rate literally doubles. It's an odds ratio of 2.2.
A doubling of the fetal loss rate simply because the local doctor hasn't had enough practice lately. I mean, how is this allowed to continue? We obviously can't ban an IPT, nor should we want to, but we can't let patients absorb double the risk just because of geography.
The entire medical system has to restructure to protect the safety baseline. The presentation outlines 2 distinct pathways to fix this. Pathway A is centralization. This is the primary defense.
Funneling everyone to the experts.
Exactly. You consolidate all the remaining dwindling procedural volume into high-volume specialist fetal medicine units. You stop letting every local clinic do 1 or 2 procedures a year, and you funnel every patient to the regional experts who do hundreds.
But what if you live in a highly dispersed or rural region? You can't just fly every pregnant patient thousands of miles to a mega clinic for a 15-minute procedure.
Right, which is why Pathway B exists for those exact geographic challenges. Audit-based accountability. In dispersed systems, you enforce strict, intense, transparent outcome tracking. Every single procedure, every outcome is audited at a central level.
And that actually works.
It does. A recent regional model proved this oversight works beautifully. They achieve zero losses out of hundreds of procedures despite low individual volume, simply through intense consultant accountability and defined escalation triggers.
I also see a final sweeping mandate here that addresses the training gap. Regardless of which pathway a clinic is on, simulation training is now ethically required.
Yes,
You
absolutely.
cannot learn on a live patient anymore. The data shows that training doctors on synthetic simulators drops the initial learning curve loss rate from a staggering 6.9% all the way down to 1.6%.
Synthesizing all of this, the unified protocol really rests on three pillars. First, precision technique, utilizing continuous HD ultrasound, double needles for twins, and adhering to strict biological timelines.
Right, the mechanical step.
Second, genomic escalation, understanding the biology of the CPM trap and utilizing high-resolution microarrays. And third, systemic governance, centralizing clinics and mandating audits to combat that NIPT paradox.
So bringing this all back to you, the listener, why does this deep dive into fetal medicine protocols matter for your life? It proves why being well-informed is an absolute superpower. When you are dealing with the healthcare system, you have to ensure you are being counseled with contemporary reality.
Exactly, you have to ask questions.
If a doctor quotes you a 1 in 200 risk rate, you now know that math is from the era of blindfolded crop dusters. You have the knowledge and the right to ask about their procedural volume. You can ask if they use the double needle technique for twins. You can ask if they've retired those outdated tearing cannulas.
Knowledge is most valuable when you understand the mechanics behind it and apply it. Asking these highly specific, biologically grounded questions doesn't make you a difficult patient. It makes you an active participant in the precision era of medicine.
It really leaves me with one incredibly provocative thought to end on. If incredible technological success like a simple, non-invasive blood test can accidentally destroy the human manual proficiency required as a failsafe, what other vital medical fields are silently losing their safety baselines right now, simply because our initial screening tools got too good?
That is a massive structural vulnerability the entire medical field needs to be auditing immediately.
We'll leave you to mull that over. Thanks for joining us on this deep dive. We'll catch you on the next one.